See. So folks, this is really a sort of an ASCO update. And what do I use to go forward? The mouse or just the... Yeah, okay. So I'm going to be talking about sort of three things. I'm sort of an expert in one of them, and I know a little bit about the other two. So I know a fair amount about kidney cancer, and I know a tiny bit about melanoma, since I don't really treat it, and I know a little bit about immunotherapies, though everyone who's in oncology now thinks he knows a lot about immunotherapies. So I'm going to pretend I know that too. Are there any actual immunologists in the room? Okay, good. That's good. So, okay, all right. I don't know if this is real or not, but I think this is. So my wife works for Pfizer. I think I have to say now that yes. So my wife works for Pfizer. So they pay for my kid's school. Okay. Okay. So let's start with melanoma. So I think a lot of you guys are familiar with melanoma. Anyway, it's a disease that the median age of presentation is about 45 to 55, and its incidence is going up because people are out in the sun more, presumably. Common, fifth among men and seventh among women in cancer. And historically, the median survival has been pretty terrible for a metastatic melanoma, about 6 months. That's probably changing. That isn't really shown here because a lot of the changes have to do with drugs that became available around 2011, 2012. And so prior to 2011, the only approved drugs were dacarbazine and IL-2, and neither of those had shown a proven survival benefit. Now, granted, I think IL-2 does have a survival benefit because there are long-term durable responses in probably around 20% of people respond, probably around 10% have durable responses, and about half of those probably survive for a very, very long time, but I don't think that has been proven per se. So what changed is around 2011, the RAS pathway therapies came out, and around half of, 50 to 60% of patients are going to have an activating mutation in BRAF over there in the RAS pathway, and there are drugs that block this. Vemurafenib, most famously coming out of people from Yale, and there are drugs against MEK right downstream of BRAF. And there are a large number of trials that have been shown, there's sort of a selection of them, showing that, number one, these are much better than chemotherapy with dacarbazine, so they're all better than chemotherapy. And the second thing that these trials have shown is that when you knock out both MEK and BRAF at the same time, those are all better than just taking out BRAF. And I've sort of shown these down here. The progression-free survivals on these are around 9 to 11, 9 to 12 months. And invariably, people progress eventually. And furthermore, again, this is going to take care of about 50 to 60% of patients who have melanoma, but not the rest. And that's where the second sort of new huge class of drugs has come in, and that's what I'm going to talk about today, which are the immune checkpoint inhibitors. You guys probably have heard of a lot of these: Ipi+Nivo, Nivolumab, Pembro, Atezo, and the newest one, Medi 4736, which I think has a name also. I think maybe Darvolumab. And I know that you hear about them every single week, but I'm not sure everyone has heard about the mechanism. So I'm going to go through the mechanisms in an incredibly simplistic, oncology-driven way. Okay, so this is my view of the world of immunology, where you have what's called an antigen-presenting cell. The antigen-presenting cell has something called MHC, which is a complex of proteins that expresses chunks of protein from its inside, okay? And these are immunogens. That's what that yellow thing is. And a T cell that has a T cell receptor that recognizes that specific immunogenic piece of whatever is going to recognize that and get activated. But of course, that's not the real story, right? That's what we sort of learn a little bit about in med school. And then there's the key second half of it, which is costimulation. So this T cell will not get activated, it will not proliferate, it will not do all the things it's supposed to do unless something called CD28 on the surface of the T cell is activated by one of two proteins usually, one called CD80 and one called CD86, that, as far as I can tell, act very similarly, okay? So there you go. That's my understanding of immunology. That's sort of the central thing that we often don't talk about, and it turns out that there are ways to downregulate this, right? Once you have T cells activated, you don't want them activated forever, or you will have sort of inflammation everywhere and cause damage to the body, right? So how do we do that? Well, one of the ways that's done is you start getting expression of something called CTLA4 on your T cells. And CTLA4 binds to CD80 and CD86 just like CD28 does. However, this somehow results in downregulation of the T cell response, and it's not entirely known how that is. It might be just direct competition, but it seems like there's also signaling from CTLA4 to the T cell to tell it to stop dividing, etc. Okay, and that is the first discovered immune checkpoint. And that's exactly what it does, right? It stops the T cell response and it slows things down. Now, there's sort of a parallel system that was discovered by, amongst other people, Liping Chen here, which is a PD-1, which is called programmed death 1 on the T cell, and it has its cognate ligand, which is PD-L1 or PD ligand 1, also on either the APC or the TUMO-R. See, this is what happens when you go from Apple to Dell, whatever. Okay, so that's supposed to be an APC or tumor. And anyway, and that's a similar system. And I think we all learn about it like this, and they sound identical, but of course they're not really identical at all. They're really quite different. And this is going to be, again, a gross simplification, but it appears that for the most part, CTLA-4 is very important for the initiation of the immune response. It's found in lymph nodes and in other places, but largely in lymph nodes where it blocks activation. Whereas the PD-1, PD-L1 system seems to be much more important, not only for activation, but for maintenance of the immune response. And that often happens in the case of tumors in the tumor microenvironment. And so what you might expect and what you see actually are somewhat different side effect profiles. And also they have different mechanisms of action, and therefore you can expect synergy. And the two main trials I'm going to talk about today are putting them both together. All right. So anyway, before I get to that, again, there have been a number of trials in melanoma looking at these drugs. The first one that was looked at was Ipi+Nivo, which is an anti-CTLA-4 drug. And I think what's notable about that is that at 3 years, there's an overall survival of 22%. And if you look at the curve, it's kind of flattened. So there are real durable responses for a very long time with this drug. And that's probably the worst of them. Okay, the other drugs are all better than that. And if you see, there are a bunch of trials comparing Pebrolizumab to Ipi, and they do much, much better. And so we're sort of ready for the next step, which is a trial that was done and presented at ASCO this year, and now it's actually published in the New England Journal, looking at randomizing patients to either getting Ipi alone, nivolumab alone, which is, an anti-PD-1 drug, or the combination. And I think the thing that was well done about, one of the things that was very well done about the trial was that they looked at the patient's tumors and looked to see about expression of PD-L1, right, ligand for PD-1. And that's going to be important later when I talk about the results. Okay, so here's sort of the key first finding of the trial, looking at progression-free survival. And the orange is the combination, the blue is PD-1 drug and the anti-PD-1 Nivo, and the green is Ipi, anti-CTLA-4. And you can see sort of what we knew already, which is that anti-PD-1 is much better than anti-CTLA-4, and the combination looks significantly better than both. And if you look at the numbers, the median progression-free survival is 11.5 months with Nivo and Ipi, and only 6.9 months with Nivo, and much less with Ipi, only 2.9 months. What's interesting about this comes up in the next slide, which is that when you separate patients into those whose tumors express PD-L1 at what's considered a high level, which is anything more than 5% of the tumor cells or of the immune cells, what you see is something quite different. So in those patients, it looks like there's no difference between the combination of Ipi+Nivo or Nivo alone, all right? Which kind of makes sense to some degree in that if you are going to be someone who's going to respond to Nivo very well because you have a lot of PD-L1 there, that may be a good enough response. If you look at the people who don't express a lot of PD-L1, the second curve, well, that looks like the original curve that we saw. Now, and this really brings up a key question, because as I'll get to in a minute, toxicity is greater with a combination of drugs. So maybe you don't need for every patient to do the combination if their tumors express high levels of PD-L1. Now, there were other differences. So in PFS, progression-free survival, there was no difference. But if you looked at actually overall response rate, the overall response rate, even in patients whose tumors express more PD-L1, was higher. Hard to know if that means anything, and hard to know if that's going to translate into anything. But I think this raises the question, again, of whether everybody needs to get both. And I think, Harriet, I think you told me that they're doing the trials of sequential. Yeah, so I think that's really the key question. At the very least, can you do them sequentially to prevent some toxicities? So let's talk about the toxicities. I know this is very easy to see. I only want you to concentrate on a few things here. Really the main toxicities that we're seeing were gastrointestinal, hepatic, and endocrine. And again, a pretty high number in the combined arm. About 15% of patients had grade 3 or 4 gastrointestinal toxicity. Anyone who's been on 12 North has seen these patients coming in with colitis and with diarrhea. We get people through this with steroids, for the most part, but it's something to consider, and they can get incredibly sick. They have to be monitored closely, and you got to get them into the hospital so they don't get dehydrated. Also, very high rate of transaminitis. And again, with those, about 20%, and again, this is treated with steroids. The last one that's notable is endocrine, and this is, again, hypothyroidism or adrenal insufficiency. And the difference between these and the first two, of course, is that they don't come back. So you destroy the thyroid's gone. It's not such a big deal because you can give these people either, levothyroxine, or in the case of adrenal insufficiency, you can give them steroids. But these are, as they notice, these events don't really resolve, whereas the others do. Now I'm going to talk about one or two other trials. This one is an awesome trial that's being done here by Harriet Kluger and Sarah Goldberg, looking at patients with brain mets with melanoma and non-small cell lung cancer. It's the only brain met trial going, right? It was. Now things have happened. But as you can see with the waterfall plot here, so these are all patients with brain mets treated with Pebrolizumab, not Pebrolizumab, as I wrote up there accidentally. And you see a lot of people have had responses. And if you look at the swim plot, notably, just to note, the red dot is when we saw a response. So about 2 months in is often when responses are seen, and there are still some people who are responding. So it's really a very exciting trial because there's really nothing for people with brain mets up until this point. Is it, Harriet? What is it?
It's the ASCO cutoff data. We've more patients since then. It's running around for melanoma in the low 20s.
Most of these people were primary brain mets was the most of their disease, right?
Yeah. Oh, you're asking, this is brain met response. Sorry,
brain met response.
To answer your question, but everyone who had a response to brain had a response in the body as well.
And then just to sort of show a little bit of what's on the horizon, as you might imagine, they're going to start mixing the BRAF inhibition with the anti-PD-L1 or PD-1 therapies. This is one trial that was presented at ASCO. Notably, when you combine BRAF inhibition, MEK inhibition, and an anti-PD-L1 drug, there was 100% clinical benefit. But that was at 16 weeks. Hard to know if you look at, I don't want to go into the details of this trial, but hard to know how significant this is, but clearly this is going to be on the way, molecularly targeted therapies plus. So let's switch gears to something I know a little more about, which is kidney cancer. Again, the median age at presentation for this disease is a little bit older, 55 to 64. Incidence and mortality are going, incidence is going up, mortality is going down. Incidence has been going up over time because of the fact that we are actually doing CAT scans for a lot of other reasons, and we're finding kidney tumors and they're actually being treated. But it still is a pretty bad disease, again, with historically a median 5-year survival of 8% once it's metastatic, which is pretty awful. Now, we have a lot of approved drugs, and they all make people feel awful and don't work terribly well. So, sunitinib, pazopanib, sorafenib, bevacizumab, and axitinib are all sort of the TKIs. These work through some VEGFR primarily type mechanism. And then there are the mTOR inhibitors, temsirolimus and everolimus. IL-2, like in melanoma, does have a small number of cures, probably on the other order of 3 to 5%. But none of these drugs are particularly easy to take, and for the most part, they don't cure. So what about immunotherapies? Well, Ipi+Nivo has been tried. Pretty small signal, about 12.5% of people had a response. And nivolumab had a much better. There was a phase 2 done with an overall response rate of about 22%. And at this year's ASCO, it was noted that in people who'd gotten nivolumab, there was upregulation of CTLA-4, suggesting that, you could combine an anti-CTLA-4 agent like Ipi with a Nivo and get a better response. And so there was this large study done looking at just the combinations, comparing them to each other. So these are combinations of Ipi+Nivo and nivolumab at different dosages. Things to note are that about half of the patients on these trials had been previously treated with these TKIs, and about the other half had not been. And the other thing to note is that one of the arms with a high dose of both nivolumab and Ipi+Nivo just was not tolerable, and so I'm not going to talk about it much. This was an early stage study, so we're going to talk about, before we talk about actually how people did in the trial, we'll talk about the side effects. And adverse events were sort of what you'd expect. Again, they're all inflammatory based. a lot of people got them. So in the arm that ended up going forward into a trial that's going on now, and that's the first arm, the one on the left, the Nivo 3 Ipi+1, there were about 34% of people had grade 3 and 4 events, and almost everybody, 83% of people, had some sort of event. And again, a lot of it was GI. So transaminitis, increased lipase was a lot of it. And of course, diarrhea. Not so much diarrhea, less than we've seen in some of the other trials. But what I think was really notable is that there were a lot of things that we had been seeing weren't seen in this trial. So no grade 3 and 4 colitis, not much kidney issues, very little proteinuria, and no pneumonitis, which had been, of course, a big issue in prior. People had died of pneumonitis before. Now, these are small studies, but still, it looks like people did pretty well. Again, the most common grade 3 and 4 AEs were gastrointestinal hepatic, and they were really higher in the arm that isn't going forward, the higher dose of Ipi. And again, no bad pulmonary events. So what about the responses? Well, pretty good. So the overall response rate in the arm that's going forward is 38.3%. So, and stable disease on top of that was 36.2%. So it's a lot of clinical benefit from this. And again, pretty tolerable. And this is, the famous swim plot. And I only wanted to bring up a few things in this, which I think is sort of key for people who are going to be giving immunotherapies, and that's going to be everybody. So first of all, most people will respond within the first 6 to 12 weeks. Those white dots are when you see response, okay? So, but not everybody. So if you guys note, there are a lot of those white dots, though it's a minority, that are way past that point. So one does not give up on immunotherapy for a while. One continues on. And in fact, the way most of these trials are designed, if you think patients are getting clinical benefit, you continue going. The second thing that's notable is that what things look like on the CAT scan, you'll often see things that, if you're not familiar with it, will look like progression, because the tumors will grow, but of course they're not really growing. What you're seeing is a huge brisk immune response going in, and actually a big immune infiltrate. So you got to be careful for these, and you don't necessarily give up on them. The other thing that's really notable about it is that anyone with a red line is someone who's been off treatment. And anyone with a black arrow is someone who's continuing to respond. And what you'll notice is there are a lot of people who are off treatment who are continuing to respond. So one of the things that's often seen with these drugs is that even if they get toxicities, and you have to take them off, the immune system has been primed, that's our assumption, and that people are still responding for a long time. So it's really quite different from what we see in chemotherapy and what we're sort of used to seeing in a good way. And lastly, for this study, here's what the progression-free survival curves look like. Again, you can see a lot of stuff leveling off. It's sort of the 30 to 40%. So, and again, the arm that's going forward has a better PFS, 68%. They did not look at overall survival. So that's really it. Just want to, in conclusion, obviously this stuff's incredibly exciting. A lot of people are, if not cured, going to have very, very durable responses. And it's very promising in both these diseases as well as in lots of other diseases, as you guys have all heard of. But you got to be really careful with the toxicities and take them seriously and get people in. But I think that's it. So if any questions?